Hello and welcome to the Healthcare Today podcast. Our guest today is Darren Kilroy, Medical Director at RLDatix, a tech and AI firm offering solutions to better improve patient safety outcomes. He has a particular interest in exploring the intersection of technology and human-centered care. Today we're talking about currently available tools for job planning, the invisible shift in clinical work, and why consultant time is still being wasted. Let's start with a question that you yourself have previously posed. If consultant time is considered the NHS's most valuable clinical asset, why do we still plan it based on past wisdom instead of new intelligence?
It's a really great question, Glenn. I look back over my clinical career of many years now, and back in my early clinical days, there was no such concept of job planning. You just turned up to work, you worked until the day was done, and the day that was done wasn't defined by 5 o'clock, 7 o'clock, 8 o'clock. There was a broad acceptance that you would finish the working day at some reasonable hour, but essentially you finished the work when the work was comfortably managed, the night shift staff were in place, you'd had a handover that was safe and comprehensive, you tidied up any bits and bobs that were left behind, and then you went on your way and left work. So in those days, the quantification of what went on hour to hour, day to day was much more based around high-level mutual professional trust. And that was a phase of clinical life which we've left behind. We still retain some elements of it, but we've moved into a much more transactional phase of accounting for clinical time. And in that respect there, we now find ourselves at a period of time in clinical professional history, for want of a better expression, where there are still the same professional expectations of the obligations you have in a career, be it a senior clinician or a nurse or any clinical perspective of a role, coupled with a much more intelligent and much more sensible desire to account for the actual time spent doing different things, because healthcare has become much more complicated. As time's gone on, the clinical care is itself complicated. The pressures and drivers upon people to perform different roles has become more diverse. And in that respect there, we have been moving really quickly to accommodate all these new expectations of how we work every day. All the new expectations around teaching, training, the formalization of that, regulatory changes as a result of reports and other things based on scandals and other things that have been in the public domain for years now that force people to think and act differently in healthcare. And we've done it at such a quick pace. We've done so much so quickly that we find ourselves now struggling to grapple with what to actually do with all the requirements, all the sensibilities, all the expectations. And that is why I believe that we still are in a phase of looking at the past to try and make sense of the future, because it becomes really tricky to find and distill out from all those expectations, which are all legacy things, and we all live around it every day. What are the really important principles by which we should determine what we do all day? We're guided by, as I say, clinical incidents, we're guided by safety alerts, we're guided by incidents and scandals, we're guided by productivity asks, efficiency gains, workforce shortages, cost containment, deficit, winter pressures, elective waiting times for operations in clinics. There are so many variables, and they all happen so quickly. We are in a phase now where we need to really think hard, and this is where technology can play a part, of all those factors which determine what we should do all day. Which are the ones which are our guiding lights on that? Can we distill that down to a simple handful or a couple of dozen or whatever it may be, simple principles that should determine what actually matters in what we do all day? And that's why we're in this muddled interim, I think, at the moment. We've got lots of things to look back on. We've got lots of technological applications which are coming on at pace, from AI to all the other things that we read and hear about. How do we make sense of all that? And I think that's where we find ourselves right now.
Talking about AI and tech, I mean, we're looking at increasingly practical steps to increase sign-off rates.
Sure.
How can AI and tech offer that solution?
It's an interesting question because there's so much potential there now. In my professional world now, we're all about workforce management, making intelligent use of the workforce resource, the human beings who provide the care. And AI layers into that in terms of making intelligent use of rosters, rotas, helping people to plan their time effectively in what's called a job plan, and looking at how AI can influence job planning to give you prompts, give you hints, give you tips about what would work best in the situation you're in. Uh, on the risk and governance side, which is a huge area of interest, of course, for all of us, AI can help there in terms of looking at the interrogation of incident reports, uh, determining what's important within the themes, a thematic analysis of things there. So there are all kinds of elements of how AI can help there, because fundamentally, the workforce in terms of the sheer number, the raw number of human beings providing the care, it is compromised and in many respects curtailed, of course, by the huge workforce spend that we incur as a health system. So AI has to layer into it and take away those elements of the human endeavor in all that AI can comfortably and safely provide for. The interesting thing we now need to work on, and we're working on really quickly, is given the rapid expansion of AI's technological capabilities, we need to be careful that it's deployed safely. And we keep an eye on, and ultimately at this stage in the development of that, have a human eye on what it's doing for us. We know AI has been really helpful, for instance, in radiological reporting in recent years. And I would rather have now, God forbid either of us need it, I'd rather have AI scanning and looking at my X-ray scans now than a human being to start with. Because it's got the ability to look at many thousands, hundreds of thousands of images and make determinations really quickly in a way that the human radiologist can't do. But that's a tried and tested place that specialty finds itself in. In other respects, we're still at a much more embryonic stage. So it's got all kinds of potential applications. And the key now is finding out which applications are of most value most quickly and working hard to develop those and refine them really, really efficiently. And I think that the role of AI in workforce management around intelligent job planning to make sure we're determining what we're doing all day and look at all the available data to guide people in how best to deploy people, and the intelligent use of AI in reporting incident management and learning from incidents, they're two crucial areas. And beyond that, then, a really interesting tease is obviously we have a huge clinical workforce in the country. We have many clinical incidents every day, many of which are minor, but some of which are really impactful. How do we use AI and other associated technologies to link together the reporting of incidents on one side with the workforce model on the other and make some new and potentially really game-changing determinations of which factors in workforce may be causing particular incidents to occur? And the more we can use technology to proactively look at that, so we're anticipating future possible incidents and mitigating them before they happen, that's the sweet spot. Because that's what we struggle with, like many health economies. We look over our shoulder at the incidents that have happened, because they've happened. We learn from it. We do an incident report. We do a deep dive, like many industries do. You do a deep dive. You get people around the table. You write statements. You analyze them. You try and learn from it. You determine what the causal factors were. Meanwhile, more incidents are occurring because today's a new day. And the more we can use AI technological applications to forward think on that, to mitigate future risk, that is the key.
Is it possible to design a national template that has enough flexibility to account for the vast differences between, say, a rural community hospital and the major trauma centre?
I think it is. And the solutions that we provide at RLDatix accommodate the vast majority of those differentiators, because if you take those two great examples you mentioned there, Glenn, from the rural community right through to your archetypal mind's eye view of a big teaching hospital, they present different challenges in some respects, but they present common challenges more than you'd imagine. So the workforce model in terms of your consultant staff, your allied health professionals, therapists and pharmacists and radiographers and speech therapists, the nursing staff and the non-clinical staff, the porters, the drivers, the restaurant staff, all of these different groups, the estate staff. And the model is broadly similar wherever you look. You have a patient demand or a burden of activity to be grappled with. You have an available resource, which is your human capital and the vans and estates and buildings and theatres that you've got to provide the care in. And increasingly now, and interestingly, especially in the remoter areas, the virtual care models where you're managing patients through a virtual ward or a virtual clinic and communicating with them on laptops and devices and tablets and phones. Wherever you look in that model, there are still commonalities around that there's a working day, there's an evening, there's a night, there's a quantum of patients to be managed. So the technology is in place to allow you to plan out those demand templates and to fit in your workforce to create a capacity model, be it in the city centre or be it in the rural setting. It's actually, in some respects, more interesting and more rewarding to see it working in a non-teaching hospital, non-city centre environment, because you're leaning there much more impactfully on the alternative working models, often of using allied health professional staff, non-medical staff, virtual models of care, community-based care, and using the technology to link those staff together is really powerful in terms of the safety of the model, because staff are linked up and you have an overview of where staff are at any one time. It also allows you to link up on the safety and governance side, because staff are able to use a common safety incident reporting platform and share learning in a way that doesn't need them to have to all be in the committee room to look at things. So the templates and the technology are there. What's really important in terms of maximising and yielding the maximum benefit from that technology is the role modelling, leadership and energy and enthusiasm and advocacy for it from all the clinical and non-clinical staff involved in those settings. And this is where life is often challenging, because in a particular healthcare provider, you have obviously a leadership team, you have many staff working for the benefit of patient care, with many demands on their time, many regulatory and governmental requirements to deliver on a whole set of metrics. And over and above that, the expectation is that you'll adopt the technology, you'll grasp it, you'll work with it, you'll advocate for it to all your staff, and then you'll try and implement it in the field to the best of your abilities and to the ceiling of the technology's abilities as well. And that's a big ask, you know. You have to work as closely and collaboratively as you can to yield all your expertise and all your energies to keep everything as healthy and as energetic as you can with using technology.
If job plan data reveals workflow bottlenecks, how do we ensure that intelligence leads to action on the operational floor and not just more reports?
It's a great question, because the NHS, taking the NHS as an example, is draped in reports. I remember from my NHS board days, you have this cycle, obviously, of preparing for the next public board meeting, behind which, of course, you've got a series of subcommittees of the board where the particular data sets are thrashed out and looked at in great detail, as they should be, and scrutinised. And so most of your working week is spent either reflecting and ruminating upon a particular set of data you had to enter and preparing for the next set of data, and with a cold sweat to make sure it's all accurate and in place, as it should be. But it peppers daily life. It's certainly in the executive teams of the NHS from my days there. So what we don't need is yet more layers of data and tables and graphs, which just sit gathering virtual dust on someone's inbox. So the really important thing is, alongside gathering data, is to translate it into useful and meaningful information and give people a really clear, comprehensive assessment of what the data is telling you. We have the ability to yield a huge amount of workforce data, clinical incident data, reporting sources from all over the different aspects of the clinical model of patient care. And we need to find ways, and we are finding ways, of channeling that and funneling it into a data set, which is not only allows people to see the raw data, because it's fundamentally patient level data and staff data that is owned by the healthcare system. The trick is then to, from that, tease out meaningful analysis and give that analysis in plain and simple language to the people who can do something with it. And I always think in terms of personas, in terms of a clinician, a director of finance, a deputy director of operations, a director of nursing, a head of midwifery. We all share a common platform of healthcare, but we've got very different expectations about what we want the data to help us with. And the more we can do to tease out by persona what the requirements are and give them an intelligent analysis, that's what's required. So actually, less is more. We gather the large data set, we funnel that, we analyze it, we come to sensible conclusions, and we give those conclusions hints and tips to the people for whom it matters and say, this is what you should look at this week. This is what might help you to look at something next month. Our analysis shows that this is the case, that is the case, and people will welcome that. And the more intelligent use we make of that data, the better, because that is what drives up standards.
NHS England's Deputy National Medical Director for Secondary Care, that's quite the title, Stella Vitt, she's observed that job planning is not just a management exercise, but a clinical leadership tool. As we've touched upon previously, ensuring effective adoption is what is going to make or break this. How do we reframe it from a burdensome administrative chore to empowering tool for consultants themselves?
Well, it's been long overdue, and I've sweated out on the receiving end of job plans in years gone by. The compliance mantra, which obviously only takes you so far in terms of your ability to zone into it, but because it is so important as the cultural leap to reframe. And the work that Stella and the team are doing at NHS England is so great, and we've worked very closely with Stella and her team in the past year or two to try and do our bit to collaborate with them to try and change the dial, move the dial on this, because many of us as clinicians have had the lived experience of it not working the way it was going. It's all around role modeling, language, culture, and belief. Job planning of itself, yes, you can measure it in terms of how many job plans have been, in inverted commas, signed off, which is essentially a shortcut way of saying, you work for me, Glenn. I'm your clinical leader. You're the clinician on the floor. We have to agree what you're going to do all day for the next year. We sit down. We look at what you did last year. We look at what's required in the department. We agree what you should do in your 40-odd hours of working time. We write that down. We sign that we both agree that, and that is essentially your job plan signed off. There might be a bit of contention. You might want to do something different this year. There may be a course to go on. There may be some new administrative tasks to do. You might want to go part-time. Any of these things would influence your job plan. But the key to your question there is when we're having that conversation, if we are framing the conversation in terms of this is a really important element of your working life, this is how we describe the clinical care you're going to deliver in the next year. This is how we support you as an employee to deliver that care to the best of your abilities by clarifying the responsibilities that you have, our expectations of you, and moreover, your expectations of us as your employer to see that you have adequate teaching and training time, you're able to have CPD time, you're able to do audit and governance and any special interests you may have. We have an expectation that you will deliver some clinical care. We will reward you by giving you some time to have administrative responsibilities. Maybe you want to go for the Royal College, you might want to be an examiner. They're all important elements of professional life. So if we use the job planning conversation and the process to support that cultural compact, then we're into a much more secure environment in terms of getting the job plan to where it needs to be. Because if you have those conversations intelligently and you come away from the job plan meeting, which I never used to do in my day, feeling you've actually had an enjoyable experience, which sounds a bit crackers, but you can do it. If you can replicate that across teams, support builds for it, engagement and trust in the process builds. And before you know it, you have increased your sign-off rate because you've actually used it as an endeavor for positive professional development. And experience shows us that when that culture is in place, compliance, for want of a better expression, with doing the thing rises. Surprise, surprise. And in a situation where people are stuck on that cultural journey, that's when you need to intervene and to help people just think about it differently. Over time, we're seeing now that improvements are being made in compliance and attention to detail, engagement in the process, because people can see the fundamental benefit of it. And one last element of this, which I've always thought is important, is there's always a conversation to be had around workforce shortages. And in many clinical teams I've worked with in the field, there's been an anguish in the team, rightly so, but often based on anecdotes, that if only we had 2 more doctors in our team, we could do loads more work for this department. We've got long waiting times. We've got patients who are queuing out the door at clinic. We have cancellations in theatre because of staff shortages. But it's often hard to get teams to come to a position where they can articulate that gap in terms of quantification and data. The job planning process, if done properly, gives you your best fighting chance of quantifying the available human resource you've got in the team. Say there are 8 of us, we've got a working week, we have obligations for clinics and theatres and outpatients and wards and all the other things that are required, teaching and training. If we capture that properly in the job planning exercise and have discussions around where we are and what we need to do, and we agree our job plans, and we flush out the fact that when all's said and done, there is clearly a gap in the capacity compared to what the demand is, The job planning process allows you to flush out that and quantify it really straightforwardly. And that forms your business case for investment in the team.
That makes complete sense from a business case point of view, but from a staff and patient point of view, crystal ball time. If it was successfully implemented, what would the tangible outcome be in a few years' time? Is it reduced waiting lists, lower agency spend, better staff morale?
Yeah, I'd like to think all of those would be the case, obviously, but I always work on the principle from work I've been involved in over the years that if you focus your energies and your efforts in terms of workforce management on the safest, best quality care, in terms of working on what we know the best clinical care model is for a given set of patients. If we know what the most efficient use of a theatre time is in terms of which staff are required and when they're required at the start and finish of a day, and all those principles and policies are well evidenced and sound and in place, and the technology to manage workforce is wrapped around that with job planning and rostering and rotas, then you will be delivering the safest possible care. And when you deliver care safely and pivot it around that, the money starts to look after itself. So in that respect there, if we continue to advocate and pivot for technology and workforce management to be a safety and quality tool, then you find the evidence shows us, and it's limited evidence, but it's growing, that care becomes more efficiently provided. Agency costs drop out because if, for instance, you have a high agency spend in a department because you can't recruit permanent staff, that's sometimes just a reality that you can't get around. If that group of staff have not gone through a really good comprehensive workforce management exercise with planning and rostering using technology and had those discussions we've just referenced before, if that has been put in place, you can almost guarantee that in the main, your agency spend will reduce thereafter if you translate all that work into the business cases required to get more investment for a sustainable workforce expansion. So that reduces workforce spend. If you look at the quantity of patients required to be cared for and your job plans reflect that you have a group of patients needed to be seen in clinic or in theatre or in ward rounds or in multidisciplinary team meetings, and you account for that properly and lock it properly in the job plan, the care of those patients, because it's been formalised in the job plan, the care of those patients, the quality and safety will improve. And in that respect there, your litigation costs reduce, your complaints reduce, so your time spent on complaints reduces, reputational risk is reduced, and all these are manifold factors in reducing costs. So the difficulty we find ourselves in all the time, of course, is translating all those endeavours into actual meaningful measures at board level, in committee reports, at pace is very challenging because the lag times on these things are quite long. But we just have to keep advocating for that. And meanwhile, taking the quick wins. If we do our workforce management properly, use the tools effectively, we can reduce agency spend in a given roster within weeks. You just can. If you use incident reports intelligently and you look for the workforce elements in an incident report and you try and tease those out and where you possibly can act quickly to close gaps in that, be it a teaching and training issue for a group of staff that leads to medication incidents, you can intervene there and put that into the rostering and roster those staff onto training very quickly. So there are quick wins. Our challenge, the excitement is how we build a more comprehensive model around that to flush out those developments in finance, efficiency, productivity down the line. But that's work that's in progress. It's exciting stuff, but it's mid-term for that.
Darren Kilroy, thank you so much for your time. That's really insightful, really interesting. And hopefully things will get rolling out.
Absolutely so. You've got to keep advocating. It's all good stuff. It's a great time to be involved in this work. It's great to talk to you, Glenn. Thanks for your time. I'm very happy to talk again anytime.
Fantastic. Thank you.